The 2026 Winter Olympics have come to a close. And although he was not able to play in the men's hockey finals, in which Canada lost in overtime because of a goal scored by Jack Hughes, a goal that cost him his two front teeth, the testament to this dangerous sport. Sidney Crosby is one of the greatest athletes of his generation. But unfortunately, his career is marked as much by his injuries as by his achievements. Now, the extraordinary resilience of this athlete is something we'll talk about today as we highlight how fascia and the nervous system can help us understand what really happened to Sidney Crosby and what kind of treatment might help him with the years he has left on and off the ice. We'll talk about neurofeedback, brainwave biofeedback, and look at how the brain and body, the brain and mind help us connect the dots and really understand how we heal. I'm Dr. Richard Nahas, and this is the New Medicine Podcast. And after spending 4 years in the ER and then 2 years backpacking in 30 countries, I spent 20 years practicing integrative medicine and landed on one key idea that can transform healthcare. What I call the Blockage Hypothesis is about how our scars matter, and treating them might be a historic medical advance. So let's dive in. Jack Hughes, a young man who scored what they call the golden goal, the goal that won the gold medal for the Olympic team hailing from the United States of America, came after an intense third period, some of the most insane hockey any of us have ever seen. Now, I played about a decade of hockey, but I've never been much of a sports fan. That being said, moments like these really help define what it means to be Canadian. And for all of the athletes who placed in the Olympics and those who didn't, what a historic memory, what an opportunity to shine. And the idea that peak performance is something that we should all celebrate and admire is something that is illustrated nowhere else like here. So Sidney Crosby was unfortunately injured in the quarterfinal. A devastating injury for Team Canada, but one that was just one too many. And learning a little bit about Sidney Crosby's story will help us understand why maybe his treatment could have been handled differently, and maybe connecting the dots might serve him well. And what that means for you as you try to navigate your healing journey, whether you're trying to make it to the 2030 Olympics or just trying to make it through the day. So Sidney Crosby was born in Halifax in 1987. That makes him 38 years old. He was a phenomenon from his early days, and he played junior hockey for the Rimouski Océanique in Quebec. I've been to Rimouski on Saint-Jean-Baptiste on an amazing motorcycle trip that I'll tell you more about in another episode. He was drafted by the Pittsburgh Penguins in the first round, first overall in the 2005 NHL draft. He was nicknamed Sid the Kid, one of the golden boys that had him pegged as being the next Wayne Gretzky, someone whose ability to see the play and make goals happen and elevate the level of play for everyone on his team was just as remarkable as his ability to skate and shoot and bounce back from injury. He was the youngest captain in NHL history at only 19 years old, a testament to his leadership skills. And his resilience, in addition to his leadership, has made him a case study for CEOs and leaders everywhere. Sidney Crosby did have a chance to score the golden goal. This was in the 2010 Winter Olympics in Vancouver. He won Olympic gold again in 2014. And those were just one part of an illustrious career. He won 3 Stanley Cups with the Pittsburgh Penguins. He was the most valuable player for the season twice, most valuable player for the playoffs twice. And he is one of a few members of what they call the Triple Gold Club, meaning that he won a Stanley Cup, he won Olympic gold, and he also won a world championship. Oddly enough, his father, Troy, was also drafted in the NHL by the Montreal Canadiens, my dad's favorite team, until the Ottawa Senators were born. Sidney Crosby's career has been linked to concussion since an episode that never should have taken place. His first concussion was on New Year's Day in 2011. The NHL Winter Classic, in which he was sideswiped by a player who didn't even need to come near him. He didn't have the puck. He wasn't looking. And as you can see, he was just blindsided. It was only 4 days later that he was hit again from behind. Again, when he didn't need to be hit. Take a look at this. What an irony that he was hit by someone called Hedman. So he was out because, as we all know, when you've had a concussion, you should not return to sport for several weeks. There's a graded return to play that's now much more consistently enforced, where you have to have no symptoms at rest, and then you have to be able to engage in light practice without symptoms, and then heavy practice without symptoms, and only then can you return to play. Well, this young champion was back on the ice after 4 days, and it should come as no surprise that his second impact was a doozy. It had him out until November, actually the following season. And he returned to the ice for 8 games. His first game back at play, he scored 2 goals and 2 assists, proving to the world how special he was. But that short-lived return had him off about a month later. And he played uneventfully, did really well the following season, but it was again in 2013 that a double impact took this guy out. This time it was a puck in the face. And imagine, this happened again, back to back. Take a look at this first injury that took place in February of that year. Well, that was a significant injury, but a relatively minor one. The champion shrugged it off and went back to playing hockey. But it was on the 30th of March, 2013, that another puck in the face had more dire consequences. Take a look at this. So this time he needed to have surgery. His mandible was fractured, and he was admitted to the UPMC Presbyterian Hospital, the University of Pittsburgh Medical Center, where a maxillofacial surgeon, that's a dentist, who's done a second residency program in dental surgery and general surgery, who's done a long residency program that includes head and neck surgery in addition to dental surgery. Bernard Costello, who at the time was the dean of the department at what they call Pitt Dental Medicine. So Sidney Crosby ended up having a titanium plate put into his jaw with screws in the bone. And when he returned to play, he was wearing a very elaborate visor to protect his face. He had groin injuries as well. He had been complaining of groin pain for many years, and several injuries on and off the ice were responsible for this. In fact, he had some groin issues even before the NHL, apparently. Well, take a look at this hockey stick in the groin, one of the injuries that had him out of play for several weeks. So again, Sid the Kid was treated by the expert of experts, the most specialized specialist, Dr. William Myers, who worked at the Vincera Institute for Groin and Core Injuries in athletes. Now, we're not exactly sure what was done, but he has had groin injuries since. And the injury that took place in the 2026 Winter Olympics was likely something that re-injured an old myofascial chain. Now, it's important to recognize that Sid the Kid should not be playing hockey anymore. If he was a normal human being, those injuries would have ended his career long ago. But this man, like many extraordinary athletes, made it to where he is today, not only because of his exceptional gifts and his talents, but also because, for whatever reason, he was genetically gifted with tissues that heal. And while not all of us have that genetic gift, the lessons that we can learn from what happened to him will serve you well on your journey. Now let's talk about the concussions first, because as we focus on research, the science of brain and mind really sheds light on how we should think about concussion and how we should think about brain health in general. One of Sidney's most significant injuries was at the Veteran Memorial Stadium on Long Island. And interestingly, veterans have a lot to teach us about concussion. I know that because a lot of the research that has been done on concussion informed the way I treated my patients when I was treating motor vehicle accidents. I had a program targeting people with chronic pain that persisted after a motor vehicle accident. And I had emergency departments referring patients to me who had risk factors for complication. Anything about their case, anything about their injury or their past medical history that suggested that maybe they might not bounce back. So when you are involved in a car accident, it's important to know whether the impact was from the front or the back or the sides. Often rear impact collisions can be more significant because you're not expecting them. It's important whether you lost consciousness on the scene, what's the last thing you remember, and then what's the first thing you remember. Do you remember the impact? Do you have any memory loss from before or after the moment of impact? That's significant because it points to subtle cognitive problems that might have occurred, even if you don't recall losing consciousness. It's important to note whether you were panicked on the scene, whether there were young children involved that made you nervous, whether there was a verbal altercation, whether you felt like you were having a panic attack, and whether you had ringing of the ears, blurred vision, dizziness. All of these point to your head being shaken in a more significant way. Now, concussion really does not require the head to be struck. Because if you think of the cranium and the brain inside, like a stalk of broccoli attached to this spine that tethers all of these long neurons that travel from the spine into the brain, you can imagine that any violent, rapid deceleration injury would cause a stretching and a shearing of those neurons, the long fibers that are the actual nerve cells in your brain. Now, we call this axonal shearing. And although there are many ways to image the brain, newer imaging techniques are teaching us that you don't have to strike the brain to injure the brain. Now, concussion has been well studied in the setting of motor vehicle accidents, but what we discovered in my practice was that these patients were experiencing more than just concussion symptoms. So they were referred to us for pain in the neck. And what we discovered is that a large percentage of them had a missed diagnosis of concussion. And we published this data because, of course, when someone comes in by ambulance, I can tell you that as an emergency doctor, your first priority is to get them off the stretcher, get them out of that hard collar, assess the C-spine, and make sure that there's no spinal injury. And so that really often focuses your thinking in one direction. And sometimes you can miss the forest for the trees. What we eventually learned was that not only did these patients have pain and concussion, but many of them had post-traumatic stress disorder. And this diagnosis, which is called the Poly Trauma Clinical Triad, the rule of three, has pain, concussion, and PTSD coalescing after one specific kind of injury. Now, this was first described in veterans, in soldiers, in Iraq and Afghanistan. But my clinical research group was the first to publish the incidence of PCT in a civilian population, specifically in people who've had motor vehicle accidents. And our work with QEEG and neurofeedback, which we'll get to next, led us to publish a third paper documenting the slower brain waves and the louder brain waves that are seen in people with this syndrome. What that means is that their brain is not working as efficiently. It's having to do more work to make those signals travel and do the work that the brain does every day. Now, this link between pain and concussion and PTSD is not just a relevant finding in this group with PCT. This teaches us a lot about how thinking about concussion beyond just the brain is the only way to deliver optimal outcomes. So we can begin by thinking about hydrocortisone. Hydrocortisone is a steroid, a corticosteroid. The other name for it is cortisol. And it's one of the hormones that your adrenal gland produces, that your body makes in response to stress. So anytime you have a stress, the first thing that happens is adrenaline. Boom, fight or flight. That's how you're ready to attack that tiger or fight that foe on or off the ice. Now, there's some very interesting evidence that hydrocortisone, also called cortisol, can prevent PTSD. post-traumatic stress disorder. Now, how can that be? Well, a systematic review that was first published in 2015 in the Lancet Psychiatry identified hydrocortisone as the only treatment that was found to reduce the risk of PTSD in people who were admitted to an ER for physical injuries that weren't necessarily diagnosed with an acute stress disorder or an emotional trauma. And a follow-up study found that this risk reduction was even greater when it was limited to people who had general medical problems. Now, why would that be? And why is it that the Cochrane group that did a review of studies looking at hydrocortisone in PTSD, among others, found a different result? Well, the Cochrane study limited its focus to people who had already been diagnosed with PTSD. And that takes 3 months, according to the criteria. For the first little while, we expect that you're going to have a reaction to an emotional trauma. We call that an acute stress disorder. But if it persists beyond 3 months with nightmares and flashbacks that interfere with your ability to function, then PTSD is what we call it. But by then, a lot of the abnormalities have been already established. Now, the interesting thing is that in this study, they did find a risk reduction of about 50%. But because what they call the confidence intervals were too wide, they couldn't tell whether that was just a fluke or not. So more research is needed. And of course it is, but looking at these trends and these clues provides important insights that help us understand medicine more clearly. So let's think about cortisol. The first reaction to any traumatic experience is adrenaline, the fight or flight response, also called epinephrine and norepinephrine. These hormones are pumped out within a fraction of a second of a stimulus. That's what makes you surge with strength and vigilance and power and reaction time so you can increase your odds of survival. But that only lasts for a few minutes, and when it fades, you feel this sort of fatigue that has to be addressed with a second wave. And that second wave of stress response is in the hands of cortisol. And that lasts for days or even weeks. And what we know now is that cortisol doesn't just help you with the physical recovery from trauma. It also helps with the emotional impact of those events by suppressing nightmares and modulating REM sleep to help you process them. We know that imbalances in cortisol, whether it's spiking too high or deficient, any irregularity in what we call this circadian rhythm, the normal physiologic response to the stresses of life, you're at increased risk of not bouncing back. Now, this is really important because we think of neurology and psychiatry as completely divorced from each other. And somehow neurologic diseases and psychiatric diseases, although they affect the same structure, the same organ, are defined as different because they create different symptoms. What I tell my patients with chronic pain about how their history of emotional trauma might be related is that all of your stresses in life, whether it's an infection or an injury or a shock or a difficult relationship, all of that stress has to be processed by the same computer. Everything goes to the brain and limits your resilience and your ability to deal with that next thing. But of course, when we think about the brain, we have to remember that it is encased in a cranium. And what we know now about how the brain works is that a lot of brain healing is related to lymphatic drainage. That's how our brain flushes wastes from the space that the cells live in. The housekeeping cells that heal your neurons mostly work when you're resting or when you're sleeping at night. So anything in the head and neck that limits the ability of lymph to drain, anything that might relate to stress in nerves in the proximity of the brain, could be expected to have an impact on how the brain heals. So whether it's a history of recurrent ear infections causing congestion in the mastoid bone, which is normally filled with air cells, or whether it's a history of chronic sinus infections with these bones and the spaces within them, literally millimeters from the vessels that supply the brain, the arteries and the veins, bringing blood to and from the brain. And of course, issues with the teeth, whether it's root canals or wisdom teeth or dental trauma, anything that might sensitize nerves affecting the mandible or the maxilla on either side, could be expected to have an impact on how the brain bounces back. So whether it's a pulled muscle in the neck or a broken collarbone, whether it's a laceration or a chronic infection, thinking beyond the brain in the head and neck is the only way to address the brain as a whole, to address the ability of the brain to heal itself in a logical, physiologic manner. Now, the ability to bounce back from concussion goes beyond the head, and it even goes beyond the neck, because one of the key principles of what I call the blockage hypothesis, the notion that your scars matter and that they can limit your nervous system's resilience and its ability to bounce back from any injury, is based on the link between fascia and the nervous system. Now, we know that movement is complex. We know that when you move the bicep, you're also moving the fingers and the wrist. You're moving the neck and the torso. We know that when you run or when you skate, you're not just skating with your legs, you're skating with every part of you from top to bottom. And the circuits that regulate this movement, whether you're an animal on all fours or a human standing on your legs, inevitably links the wrists to the ankles, the elbows to the knees, the shoulders to the hips, one side to the other. And this twisting movement that forms the basis of how we do everything forces us to see these long chains of fascia through the lens of traditional Chinese medicine. Because thousands of years ago, the Chinese defined acupuncture channels, what they call meridians, the Jingluo, that the body is made of, as the key structures that need to be treated in order to maintain health. Now, centuries ago, European doctors traveled to China, heard about this, and dismissed it as nonsense. Not only did they assume that European science knew best and these indigenous people knew nothing, but they actually dissected the human body and could not find the meridians that they spoke of. But if meridians can be recognized as the path of least resistance, created by long chains of fascia that distribute tension along multiple structures, connecting the leg and the torso, connecting the arm and the neck, then it becomes clear that not only do our injuries matter because they might make our nerves sensitive, affecting the circuits that control parts that are connected, but they also might affect the way that fascia allows your body to move, creating tension in the neck when you've had a wrist injury, or creating pain and concussion symptoms that persist in the head after an injury in the groin and the leg. Here's how. The kidney and the bladder meridians were described as channels that travel along the inside and the outside of one part of the body. Now, focusing on the bladder meridian for just a moment, we can see how acupuncture points are described on the outside and the back of the foot, traveling up the calf, into the hamstrings, along the sacrum and the gluteals, into the multifidi and the muscles that attach the pelvis to the rib cage and attach the pelvis to the cranium. And you see how these channels are not just travel up the back, but travel up the back of the head, around to the front of the skull where they attach at the top of the eyeball. Now, these acupuncture channels can be linked to myofascial structures that connect muscles with names. We don't need to think beyond the anatomy that we were taught. We just need to recognize that you can't twist your hip without twisting your shoulder. You can't bend your knee without adjusting your core. And when we think about Sidney Crosby and his groin injuries, we have to ask ourselves, where does the groin begin and where does it end? Because as we can see, the thing we call the groin includes muscles above the pelvis and muscles below the pelvis. Those little triangles we call the pyramidalis muscles, and below them the adductor muscles that attach to the femur of the thigh. And those pyramidalis muscles meet at a line that we call the linea alba, the white line that travels up and attaches to the base of the sternum. The sternum travels up into the neck, attaching not only to the collarbones and the sternocleidomastoid muscles, but also into the muscles of the throat, the so-called hyoid muscles, which attach to the base of the jaw. So when we look at Mr. Crosby's ankle injury, and we look at his groin injury, and we look at his concussion history, we have to ask ourselves, where does it start and where does it end? And whether you're a hockey player or a woman giving birth, the pelvic floor is a key structure here, because the front of the pelvis, where the groin is, wraps around the bottom of the pelvic floor, that bowl that holds your bladder and your uterus and your other structures in place, and attaches to the tailbone, the coccyx, which is the base of the sacrum. And that bone that we call the keystone of the arch, traveling from one hip to another, connects from the bottom to the middle to the top. As you can see, the acupuncture channel that's described traveling from the occipital to the frontal muscles at the base of the skull, corresponding to a line that travels all the way up the front and all the way down the back, like a tube that twists back and forth. We'll talk more about this structure of the body in future episodes, but the concept that you are made of long chains of fascia is so fundamental to understanding why your wrist can affect how you bounce back from a concussion. And so can your ankle. And ankle instability isn't just a cause of hip pain. It can be a cause of neck pain too. Because you can't shift back and forth on your feet without shifting the top of you as well. This is completely missing from the science of medicine. This is not mentioned in any textbook. No one with neck pain has their ankles examined, and no one with ankle pain has their groin examined. And this is how medicine must change. The concept is simple. Every injury matters, and every time you have a new problem, your treatment should include some form of therapy to address your old problems too. You have to treat the whole person every time one part of that person has been injured. Now, this brings us to our intervention, because rational prescribing is all about navigating your healing journey using yourself as an N of 1 study. Once you've gone beyond the guidelines, you need to recognize that just because a therapy was more effective in a group that got it than a placebo was, that doesn't mean that that therapy is going to work for you. And we've talked about natural health products, vitamins, herbs, as things that might help. But neurofeedback, EEG biofeedback, is an example of a therapy that's delivered by a provider that makes it important to think of it in a different way. Now, a normal EEG, an electroencephalogram, is something that neurologists typically use to look for seizures. They typically scan the tracing with their eyes looking for spikes. But neurofeedback relies on data that comes from something called a QEEG, a quantitative EEG. That's data that comes from a standardized recording of brain activity that is analyzed by a computer, looking at thousands of parameters to try to identify abnormalities that make your brain different from a database of thousands of brains. There are many ways to image the brain. There are X-rays and CTs and MRIs and MRAs and PET scans. And there's a new way to image the brain called diffusion tensor imaging, which allows us to see concussion injuries that MRIs have missed, looking at very precise images of axons and identifying that shearing that can occur when torn fibers leak out the water that's inside them. But an EEG is looking at a different kind of data. It's not showing us a picture of what the brain looks like. It's showing us how it functions in real time using electricity as the thing we measure. Now, we did QEEGs in hundreds of patients in my clinic, and many of them went through a protocol of neurofeedback. We used a 19-lead QEEG, but now there are some research labs using 32 and 64 and even 128 lead EEGs. But the 19 lead allows us to identify which lead is producing abnormal electricity. And neurofeedback is about treating the most abnormal lead. And not just treating that spot in general, but targeting the frequency band that's most abnormal. Whether it's the delta or theta or alpha or beta that is too high or too low, neurofeedback allows you to pick the most abnormal spot and train the most abnormal frequency up or down. It's literally a window into your brain in real time, like a mirror that helps you shave. Now, the quality of neurofeedback depends on how it's done. Not just on the type of feedback you're given. If it's a video game that you're playing and the game plays when your brain is in the right zone, and it stops when your brain is in dysfunction, or whether it's a movie that pauses and plays when you go out and in to balance, the feedback matters. But the provider who's delivering the feedback also matters. Some of them need to give you coaching between sessions, because a typical feedback session is about 2 to 3 minutes on and then a few minutes off, and then a few minutes on and a few minutes off. And each one of those sessions is like doing a set with your biceps. You do a set of feedback and then you rest. And in those rest breaks, the provider pairs what you've been doing with some of the activities that you need to learn to do better, whether it's visualizing yourself on the ice or learning to focus when you're doing your homework, whether it's balance when you're standing, or whether it's speech when you're nervous. Pairing the activity with the feedback matters. And so this is an example of how neurofeedback is harder to prove than a drug. And in the same way that we've talked about herbs that can vary from one study to another based on the dose, the duration, the frequency, so can neurofeedback. Not just based on how long it's done, how frequent the sessions are, and what kind of feedback is given, but also by the quality of the coaching that's delivered by the provider. So if you have had a brain injury, or if you are using neurofeedback to treat any one of many of the disorders that it's been studied in, ADHD, schizophrenia, depression, neuropathic pain, anxiety, or whether you're simply looking for peak performance like the dancers or the surgeons that have been studied by researchers over the years, it's important to know that you're not doing a trial of neurofeedback. You're doing a trial of this neurofeedback with this person. Now, in some cases, you can do neurofeedback every day or twice a day for an intensive course of treatment. But in many cases, neurofeedback can be tiring, especially if you've had a concussion. So you may need to space those sessions out according to your ability to tolerate it. Maybe twice a week, 3 times a week. And maybe you need more sessions or fewer sessions. But if you've done 10 sessions and you're feeling nothing, you might want to think about varying the protocol or the provider, or just trying something else. A full course of neurofeedback might require 30 or 40 sessions. And especially for kids with ADHD, where it's been most rigorously proven, it may be necessary to come back for a refresher every 2 to 3 years. 5 to 10 sessions that help you pair the feeling of being in the zone with the cognitive work you have to do. And that's why the systematic reviews, despite tons of evidence that neurofeedback can improve ADHD, still suggest that further research is needed to standardize protocols and set standards for practice. And this is important, but it really doesn't make sense to assume that the treatment that's best for you is the treatment that's best for everyone else. If you're looking at guideline-based care in drugs that have been well studied in large double-blind clinical trials, of course, you do what the evidence tells you. But as soon as you move beyond guideline-based care, you have to think of yourself as an N of 1 trial and do one thing at a time. Stick with what works, let go of what doesn't, and take a data-driven approach to your healing journey so you can get better faster with less wasted time, less wasted money, and less frustration. That's it for this episode. The Olympics inspired me. Even though I'm not an athlete, excellence inspires us all. And I'm very proud of all of the athletes from Canada and from every other country. I think that no matter where you're from, we should cheer for all of them. And we should remember when we see Sidney Crosby bounce back from every injury that he has sustained, and not only play like a champion, but behave like one. It's important to remember that we're all a little broken, but we're all beautiful, and we can all heal. See you next time.